We're going to go ahead and get started. Thank you. And I want to welcome you for another wonderful lecture for the Transplant Institute and our lecture series. My name is Marwan Abu-Zoud, Director of the Transplant Institute, and it's always such a pleasure to host a partner or partners from our team who will be talking to us today and expanding our knowledge base on nutrition. You are what you eat at the end of the day, and we're all living it every day. Nutrition is an integral part of transplantation, and this is why we picked up this topic, and we hope we've done this before, and we hope to make it a recurring theme. And today our speakers are Mr. Tom Piotrowski and Ms. Nancy Park. Tom, many of you have known now for a long time. He's one of our earliest dietitians for over 20 years now with the Transplant Institute. He earned his bachelor's degree in dietetics from Central Michigan University, where he also got a master's degree in the science of nutrition. And for over 20 years, he's been delivering support for our team for all solid organ transplants. And more importantly, he was also in the early startup for our nutrition for intestinal transplant recipients, which you all know pre-transplant, post-transplant, peri-transplant are very complicated patients throughout. So thank you, Tom, for your help with that program. He's very active with the American Society of Transplantation and also with the American Society of Parenteral and Enteral Nutrition. He's done a lot of work, and is more recently, you've all seen him with his interest in sarcopenia and frailty, and he's worked with our metabolic clinic and also with Dr. Nagai, where he helped us understand sarcopenia and frailty in our patient population, published several research articles and case studies with our team in our venue. Ms. Nancy Park brings several decades of expertise. I'm not going to say how many. You mentioned it in your note. And, you know, I thought she must have been 5 when she finished her education. She does our nutrition for the transplant outreach team and kidney transplant, both pre and post-transplant, and also is very active helping with the liver and metabolic clinic. She has a special interest with the metabolic dysfunction-associated liver disease and fibrosis. Very active clinic with our hepatology team and our surgical team that we're very proud of. She's also gotten her bachelor's degree in science and dietetics and also Master of Human Nutrition in Eastern Michigan University. She's been very busy with the Commission of Dietetic Registration and Academy of Nutrition, where she got certified as an advanced practice credential provider. And also very busy with many state and regional societies, and she was president of the Michigan Society for Parenteral and Enteral Nutrition. So I thank you both for your service, and today they're going to be talking to us about the role of nutrition in our transplant organ recipient, eating right for life. Thank you so much for your being with us.
All right, thank you, Dr. Abu-Zoud. I appreciate everyone showing up in person today and everyone online as well. Thank you. And, you know, I think I can speak for Nancy too. Hopefully by the end of this presentation, you'll have at least a little bit of a better understanding of what we do as transplant dietitians here at Henry Ford, and a better understanding of the impact of nutrition and what it can have for the success of our transplant patients also. We have no financial relationship, and presentation doesn't include discussion of off-label or investigational use. So when looking at the impact of nutrition, you know, nutritional abnormalities are very common in chronically ill patients with end organ disease. In the transplant population, nutritional issues must be addressed all throughout the transplant continuum, pre, peri, and post-transplant. Nutritional assessment, education, therapy are all critical components of care in this population. And you know, obviously, while the nutritional needs and treatment can vary based on disease type and type of organ transplant, the goals really are the same. We want to maximize pre-transplant nutritional status to maintain transplant candidacy and improve post-transplant healing and recovery. And on the post-transplant side, monitor early and long-term nutritional status to promote healing, manage weight, minimize medication side effects, and help meet overall nutritional requirements. Education is a big part of what we do. So we always try to educate patients regarding overall nutritional risks in relation to transplant, negative outcomes that can be related to poor nutrition, and interventions to help support their long-term success with their new organ. So focusing a little bit more on the pre-transplant side, really our primary focus is minimizing the effects of progressive organ dysfunction. We want to promote adequate protein and calorie intake, really help patients maintain muscle and energy stores pre-transplant, and also correct nutrition abnormalities that are associated with organ failure, optimize weight, whether it's working on weight loss or weight gain, and to help maximize the quality of life while managing their symptoms. And these symptoms, can be numerous, fatigue, hypertension, hyperglycemia, malnutrition, electrolyte abnormalities, and more. These can all be common symptoms pre-transplant. Overall nutritional assessment is crucial for our patients. And that includes past medical history, looking at any history of chronic disease, infection, any recent hospitalizations and prior surgeries. Trying to get a good idea of any significant weight loss or weight gain. That's always something that we assess in our patients. A review of current medications, non-prescription medicines and supplements. A thorough dietary history, which really helps to give us, helps us to tailor our education a lot more for patients. We can get a much better idea of overall dietary habits based on dietary history. Physical exam, including vital signs, height, weight. And then also looking at physical signs, so signs of nutritional deficiencies. So in our patients, we can see things like brittle hair and nails, hair loss, mouth ulcers, bleeding gums, poor night vision, itchy, flaky skin, just to name a few. So always looking at some of those physical symptoms of malnutrition also. I'll talk a little bit too about some of the pre-transplant estimated requirements. Now, these are kind of general guidelines, but for most of our transplant patients, they can be appropriate. So for energy maintenance, we can use basal energy expenditure times a factor of 1.2 to 1.3 for 30 calories per kilogram. And some of that is, of course, going to depend on activity level also. For weight gain, or for patients with severe malnutrition, basal energy expenditure times a higher factor of up to 1.5 or 35 to 40 calories per kilogram can be used. And in cases of weight loss, we can get a good idea of what their maintenance amount of calories would be, and then subtract 500 to 1,000 calories for a calorie deficit to try to promote weight loss. And this is something that can depend on, of course, on current intake and ability to exercise. When looking at protein, so for general maintenance, typically the range of 0.8 to 1.2 grams per kilogram is appropriate. However, in cases of repletion or severe malnutrition, 1.3, even sometimes up to 2 grams per kilogram might be used to help prevent further muscle loss. And of course, among our kidney transplant patients, all of our dialysis patients have higher protein needs also. So for hemodialysis, generally 1.2 to 1.5 grams per kilogram, and even higher in our peritoneal dialysis patients, even up to 1.5 grams per kilogram. So looking a little closer at malnutrition in organ failure, malnutrition can be a common condition among patients requiring organ transplant. Malnutrition and low body weight can contribute to a whole host of complications related to transplants, increased morbidity and mortality, decreased function, quality of life, increased frequency and length of hospital stay, and even higher overall healthcare costs. So you can see the prevalence among our pre-transplant patients, it is significant. So among alcoholic cirrhotic patients, it can be in the range of 34 to 82%. And then around 27 to 87% among some of our non-alcoholic cirrhotic patients. In our kidney transplant patients, up to 40% of patients on hemodialysis or long-term peritoneal dialysis have been estimated to have some degree of malnutrition. Close to half of our potential heart transplant patients with heart failure can have a degree of malnutrition. And then among our lung transplant patients, especially in conditions like cystic fibrosis and obstructive diseases, close to half of those patients have been estimated to have malnutrition, and then around 30% of patients with interstitial lung diseases. So you can see these prevalences are quite high. So you can see on the left the many issues that can lead potentially and contribute to malnutrition in our transplant patients: anorexia, muscle wasting, GI issues, nausea, vomiting, diarrhea. Functional issues can play a big part: difficulty chewing or swallowing. Social factors can play a really big role too: limited access to food, also early satiety, depression, fatigue. Any restricted diets. We want to try to, in some cases, even try to liberalize diets as much as we can to try to improve oral intake, hypermetabolic states, nutrient malabsorption. And really, since any of these issues can contribute to malnutrition, there's a lot of these. So we really, nutrition assessment is really crucial to try to identify any of these things that may be contributing. And, but we still want, obviously, nutritional needs need to be individualized. So there are other factors, underlying disease state, nutritional status at the time of evaluation or surgery, any post-op complications. So there's a lot of other factors even besides, some of these common issues that can contribute to malnutrition. So based on, as far as diagnosing malnutrition, the Academy of Nutrition and Dietetics and Aspen actually came together and came up with diagnostic criteria for malnutrition classification. And this is both looking at patients with acute illness and chronic illness, and also taking into account social and environmental factors. So this figure kind of shows that. And a lot of information here, but if you really focus on the middle column in the blue, obviously the majority of our transplant patients are going to fall under that chronic illness category. And then if you look at the clinical characteristics on the left, the first is energy intake, so getting an idea of what their actual calorie and protein needs are. And then, if we find that based on those requirements that patients have less than 75% of those estimated energy requirements for over a month, that's one criteria of malnutrition. Of course, looking at weight loss over certain time periods, especially over, if they've had weight loss greater than 10% over 6 months or greater than 20% over 1 year. Those can both be criteria for either moderate or severe calorie malnutrition. Getting a good physical assessment of their overall muscle mass, so muscle loss in the temples, the clavicles, looking at shoulders, scapula, the thighs. These are all areas that we can look at and kind of giving a degree to that muscle wasting, either mild or severe depletion. Sort of the same thing, doing physical assessment of body fat in areas where we might see loss of subcutaneous fat. You can see there, also giving a degree to that, either mild or severe depletion. Fluid accumulation, is also can potentially be a sign of malnutrition that we want to look at, either mild or severe. And then an overall functional assessment can be a part of this also with using grip strength. So with moderate protein calorie malnutrition, it really doesn't apply there. But if it is found to be measurably reduced, that can potentially be another measure of severe protein calorie malnutrition. And I think it's important to note the message at the bottom too, referring to albumin and pre-albumin, that they're really not meant to be used as nutritional markers. They're really more acute phase reactants, and they're really not directly indicative of overall malnutrition. They can be indicative sometimes, especially in our hospitalized patients, of morbidity and mortality, but really not for actual clinical malnutrition. So I think that's always something good to keep in mind. And then what I mentioned already within the malnutrition criteria, we often use the nutrition-focused physical exam. So when looking at, the first set of exam areas, looking at the head and face, so normally, around in the orbital region, slightly bulged fat heads in the orbital region, and then in the temple region, there's normally well-defined muscle, flat or slight bulge. But then if you look to the far right with severe malnutrition, patients will often have a very hollow look, depressions around the eye, dark circles in saggy skin, and then in the temple region, deep hollowing and scooping, lacking muscle to the touch. Facial bone structures are, overall, you can see those facial bone structures very well. They're very well defined. When looking at the upper chest, again, on the left, showing kind of what those look like normally. Usually well-defined muscles surrounding the bone. Clavicle bone typically isn't too visible, usually in males with normal nutrition. It may just be slightly prominent in females. And then rounded curves, nice rounded curves at the arm, shoulder, and neck. But in severe malnutrition, you'll see the protruding and prominent bones with low surrounding muscle mass, especially when palpated. And then the shoulder, the arm joints, generally look very square in severe malnutrition. And then also looking at the upper back, that's another area that we can sometimes look at. You can see with normal nutrition, bones really are not too prominent and really no significant depressions. But with severe malnutrition, they may have prominent or visible scapula bone or shoulder blades, notable depressions between the ribs and the shoulder and spine as well. You can really physically see those differences. So some of the interventions that we can use for malnutrition in transplant in general, I did mention earlier, sometimes liberalizing diet may be needed to help to improve oral intake, encouraging small frequent meals and snacks, and trying to incorporate a lot more nutrient-dense foods, try to kind of help patients get sort of the most bang for their buck, especially if there are issues with appetite. Education on high-calorie, high-protein meals and snacks, so even as high as 35 to 40 calories per kilogram per day may be needed. In chronic disease, some of the protein requirements may be 1.2 to 1.5 grams per kilogram. But with severe malnutrition, even as high as 2 grams per kilogram may be needed. Oral nutritional supplements, trying to incorporate those can always be useful. Whey protein especially can be ideal. It contains all of the essential amino acids. It's high in leucine, which is found to be a very important amino acid to help with muscle protein synthesis. And in general, it's highly absorbable. Sometimes appetite stimulants can help our patients improve oral intake, so we will sometimes incorporate those. Specific vitamin mineral recommendations, especially based on deficiencies, whether physical deficiencies or if we see deficiencies based on blood work. Calorie counts are really important to try to get, we want to get the best idea if we can of what patients are actually taking in either in the hospital or at home. It just really helps us to kind of improve our assessment. Nutrition support, in some cases may be recommended, especially for patients who are worked up in the hospital, either parenteral or enteral nutrition in some cases of severe malnutrition. And weight monitoring, really trying to stay on top of patients and making sure that they're making progress, good regular progress, and hopefully to improve their nutritional status. I also wanted to touch a little bit too on sarcopenia and frailty, and these are probably two phrases that you see often including in transplant, but also in other fields. And a lot of times these two terms are used interchangeably, but they really are two different clinical conditions. There is some overlap, including physical tests like low grip strength, low gait speed, but they are still distinct clinical characteristics. Sarcopenia really can be seen as like a driving factor for frailty. In sarcopenia, it's defined as a gradual loss of muscle mass, strength, and function. And when you look at the diagram on the right, you can see that sarcopenia really first kind of leads eventually to a functional decline. And then once patients actually cross a certain threshold, they can start to have poor strength, physical fatigue, and then these are things in turn that can start to lead to walking and balance difficulties. And then you start having the effect of where patients will then start to go out less, they'll sit more at home, and really start limiting their physical activity entirely. And this is really when frailty really starts to set in. And you can also see here, if you look to the left of the figure, where chronic diseases, diet, or poor nutrition, these are stressors that frailty, it can make patients much more susceptible or vulnerable to these stressors. And it should also be noted too that really like the three areas that are defined here under frailty, that they're not isolated. So clearly once sarcopenia progresses to frailty, you can get this vicious cycle that progresses, and it can be very difficult to kind of get patients out of that also. There are a number of different measures that we can use for frailty in our transplant population. Very common one is the Freed frailty phenotype. That's one that's very common use even in a lot of transplant centers around the country. At least among our liver transplant patients, we do use the liver frailty index. So this is an objective standardized measure of frailty in patients with cirrhosis. And it really encompasses three different physical measurements. So the first is grip strength. So we do an average of 3 trials. We try to measure that with the subject's dominant hand using a hand dynamometer. And I usually have the patients hold it for about 5 seconds or so that we can get a good accurate reading. And then we take an average of those 3 trials. The second are timed chair stands. So it's number of seconds that patients can do chair stands, getting up out of a chair without pushing up on the arms of the chair. So basically keeping their arms folded across their chest. And then we keep track of how long it takes them to do that. And then the third is balance testing. So the number of seconds that the subject can balance in 3 positions, side to side, semi-tandem, so with their feet kind of staggered. And then the last is tandem, or with their feet heel to toe, essentially. And we want to see if patients can try to do that for a maximum of 10 seconds each. In a lot of our frail patients, often they can do like the side to side, the semi-tandem tests pretty easily. But the heel to toe is one that they typically kind of fail on. But these are the tests that are involved in that frailty index. And then we can take these measurements and enter them into the liver frailty website to give us a liver frailty index score. But when we're looking at this score, that might be a little bit hard to see there, but the patient has a score 5.0, which is considered frail. But we essentially want to look for a score, that's under 4.5. Also, if we've tested patients, a number of times and we see an improvement in their liver frailty index, that's also something that we like to see, and that can be certainly a positive when we're evaluating patients for transplant. Some of the interventions that we can use for frailty, first of all, referral to physical therapy. We want patients to try to get, physically stronger as really as fast as they can, and typically physical therapy is the best way to do that, or as for exercise. Aggressive nutrition intervention, small frequent meals, as mentioned earlier when talking about malnutrition, those higher protein intakes, even up to 1.5 to 2 grams per kilogram per day, and oral nutritional supplements, sometimes even up to 3 times daily, to really try to maximize those calories and protein with patients as much as we can. Really good, generally, to try to recheck the liver frailty index every 4 to 12 weeks. I usually like to try to get a good reading, anywhere from like 4 to 6 weeks after patients actually start physical therapy, and then we can continue to try to track those improvements. There's some research out there too, looking at vitamin D, that shows that checking and correcting vitamin D deficiency may even be beneficial in patients with frailty as well. So also another intervention that we can try. Another way that we can look at muscle loss and fat loss is using body composition testing as well. So on this slide, I included 3 of the more common methods that are used in the clinical and research settings. But when looking at CT, MRI, this is really considered to be the gold standard really for body composition analysis at the tissue level. It's validated, precise. You don't really have to worry about volume status or overhydration when using CT or MRI. And with MRI, there's no radiation. However, some of the cons, it's costly, they're not portable. Skill is required for interpretation, And really, in regards to sarcopenia, there really are no standardized cutoffs when using CT or MRI. Another method is using DEXA, which is basically a whole body scan, body composition using an X-ray source. It's quick, there's limited radiation, and it's also very precise. However, it can be costly, not portable. It is dependent on volume status, on hydration status, and skill is also required to interpret those results. One that we have used here at Henry Ford is bioelectrical impedance analysis. So this is the scale that we have up on K16 that we can use for BIA testing. It's painless. It's a non-invasive application, basically of low intensity electrical current. Some of the pros, it is portable, and it for the most part, it's pretty cost effective. However, it is an indirect measurement, and errors can occur due to hydration status, or if patients exercised, in a close period of time to where we took the measurement. So essentially, for this scale, patients will stand on the scale. They need to be barefoot. They need to have their feet on both of those sensors on the bottom also, and then they also put their hands on sensors on those the black arm rails that you can see there. And they also cannot have a pacemaker, defibrillator, any implantable electric devices either. And then they stand on the scale. And while the analysis is running, they need to stand perfectly still too to get an accurate reading. But the analysis is only about 20 seconds or so. It's pretty quick. So, so with that BIA measurement, we can use that. And you can see here, this is just kind of a sample out of what some of these measurements will look like. So we can get body mass index, fat mass index, and then fat-free mass, and also fat-free mass index. Fat-free mass is essentially just the difference between weight and fat mass. And this can be one indicator also of malnutrition. Fat-free mass index under 17 for men and then under 15 for women can both be criterion for malnutrition. We can get a really good idea of skeletal muscle mass also, and with that scale, we can get skeletal muscle mass in different parts of the body. So in the torso, in each arm, in each leg. So it gives us a really good picture with that. An ideal of fluid, total body water, extracellular water. BIVA, which is essentially an analysis of their fat-free mass, visceral adipose tissue, and then phase angle. And phase angle is a reading that we can get from this that's basically a measure of the quantity and quality of somatic cells. And it has been found even in some research to be another indicator of basically overall nutritional condition. And we have used these BIA measurements, both myself and working with Dr. Nagai. We've used these quite a lot in our intestine and multivisceral transplant patients. And they've been very useful, especially we've been able to kind of track their improvements post-transplant. Especially their improvements with, once they're on the outpatient side, in their overall nutritional status, improved nutrient absorption post-transplant, especially after ostomy reversal. We found that we really started to see a lot of really good gains and really good improvements in their overall nutritional status when we track their BIA measurements regularly. So it's been pretty useful, especially in that transplant population. And the last topic I'll touch on here also is pre-transplant obesity. Now, obviously, I think we all know that obesity, it's a major concern among pretty much all of our transplant programs. Really a big reason for this is the prevalence of obesity in the US and worldwide has reached epidemic proportions. Currently, about 40% of the adult population in the United States is living with obesity. And this, in turn, will increases the prevalence of patients with obesity requiring solid organ transplant. Additionally, weight gain is, normally expected within the first year after solid organ transplant. So that kind of comes with a proportional increase in the rate of cardiovascular events and long-term mortality. So, with obesity, particularly that truncal distribution of fat, also comes with a a lot of complications with transplant. It can increase the risk of surgical complications, delay postoperative recovery and wound healing, and increase the risk of graft dysfunction. Of course, BMI cutoffs vary based on organ, but generally anywhere from 35, 40 is what we use for most patients. And, I think another note is that a multidisciplinary approach really is crucial for obesity treatment in our transplant patients. It's a challenging condition to try to treat. So doctors, surgeons, our PAs, our NPs, our amazing pharmacist team, all of our psychologists, I mean, we all kind of play a part really in trying to treat obesity. As transplant dietitians, we really work very closely with patients pre-transplant to try to reach their weight loss goals for transplant. So a thorough nutritional evaluation is always needed. Education on calorie restriction, healthful eating, we'll often teach the healthy plate model and other methods for healthy eating or gradual weight loss. We want patients to try to lose weight always more gradually is where patients tend to keep it off the best, but also incorporating behavior modifications, SMART goals, encouraging patients to do more self-monitoring at home, teaching about portion sizes and ways to limit portions at home. These are all things that can be really helpful. Of course, physical activity recommendations. Physical activity is a huge part of trying to treat obesity as well. And really trying to follow up with patients regularly. Accountability is really important, but also following up with them regularly to sort of make sure that they're staying on track to try to reach their weight loss goals. A few other interventions that we can use here at Henry Ford also, the Henry Ford Weight Management is another resource that we can use, especially if patients are continuing to have a really difficult time trying to get that weight down for transplant. Our liver metabolic clinic has been a huge resource for our liver transplant patients, especially headed up by Dr. Gonzalez and Dr. Venkat. Nancy will talk more about that a little bit later in her section, but that's also been a very important resource for a lot of our transplant patients. And this is an interesting slide that I wanted to include also. So this was actually a study that was just released just last month in the Lancet Diabetes and Endocrinology, looking at potentially other ways that we can try to diagnose obesity. So when you look at that figure, it's pretty busy, but obviously we know that the limitations of BMI for assessing obesity, they can include, that it doesn't really reflect overall body fat distribution or overall metabolic health. People can have high muscle mass and have a high BMI despite having normal fat mass. And at the same point, people with excess body fat, they may not even have a BMI greater than 30, but they can still have health risks and metabolic risks. So this is some new data that really kind of recommended adding new measurements of body size or using direct methods of fat measurement that can be helpful or kind of a better way for assessing obesity. So one is that we can still use BMI, but try to do another measurement along with it, such as waist circumference, waist to hip ratio, or waist to height ratio, or using two of those measurements. And then the third option is using direct body fat measurement. So either using DEXA scans, as mentioned earlier, or bioelectrical impedance analysis. So, that's really the main point is really trying to improve how we can identify obesity and confirm excess body fat. So as I mentioned, BMI can still be used, but really trying to get more information on patients to try to kind of better diagnose obesity. And, obviously with this, further research is needed, but, this may be kind of an area of future direction that we might be able to use, particularly in the transplant population with how many patients that we do see pre-transplant with obesity. And this may be something helpful for the future. So, with that, I am going to hand things off to Nancy. So thanks.
Thanks, Tom, and thanks everyone for showing up today. It's been such a joy for me to join this team officially about 2.5 years ago. I've only been with Henry Ford about a fifth of my dietetics career, which is not very much, but I've learned so much and had such a great time working as part of this complex team. So Tom had talked about what we're focusing on with pre-nutrition therapy prior to transplant, that is. I'm going to focus a little bit on the post-transplant side of things, and some of the biggies are going to be listed here. One of the biggest ones is the interactions of foods and medications. So any food that is metabolized along the same route as any medication that goes through the P450 system is going to have an impact on drug absorption and drug utilization, drug metabolism. So, you know, every now and then this happens where TACRO levels are really high and we have to dig deep. Were you taking your medication? Have you had nausea and vomiting? No. Are you eating, you know, any of the fruits that are supposed to avoid? I'm not having any grapefruit. I'm not having any pomegranate. Well, what are you doing? Well, I bought a case of pomelos from my little nephew, Joey, who was selling them for, you know, his band going to New York City. So I really wanted to support him and I couldn't let him go to waste. So I started eating them. We really have to dig deep sometimes and find out how much people are taking. And then there's the other people who drill you down the other way. Well, I can't have grapefruit. Can I have sport? Can I have a grapefruit flavored candy? And you're like, you know. And so the list goes on and on with these. But some of the very common ones we know, of course, are pomegranate and grapefruit. But we also want to pay attention to Seville oranges. Nobody knows what that is anymore. Nobody knows what orange marmalade is anymore. I know they still have it at Denny's on the table in the little tiny packet, but that's okay. Starfruit and, of course, the dreaded pomelo are on there for post-transplant patients. And it's funny because we think, how much would people have to take to really interact? Probably a lot. One of the studies I looked at with the herbal stuff, a man was taking 15 teaspoons a day of turmeric in one of the case reports, and guess what? He lost his heart transplant. So, you know, this is a random case study, right? But it's in the references, but we want to pay attention. And people sometimes get very fussy about herbal supplements, and this is something Tom and I really screen down for, as do the psychologists and pharmacists in our pre-transplant evaluation. How willing are you to give up your ginger tea every day, 4 times a day, or your garlic supplement that has a concentrated amount of garlic in it? Well, can I have garlic in my mashed potatoes? Yes, you can have garlic in your mashed potatoes, but we don't want you taking large amounts of supplement form. This is just a table from the article I referenced in Renal Dietitian's newsletter that was written by 2 team members at Rush Medical Center in Chicago. A dietitian and pharmacist teamed up to write this great article on food-nutrient interaction or food-drug interactions, and it goes through the various types of anti-rejection medications we provide to the patients and whether or not the medication inhibits the absorption of the medication or the metabolism of the medication, or whether it induces it. So that's a nice reference table there. Food safety, this is another biggie. And as a person on the other side, you know, relatively well and healthy person who doesn't need a transplant or hasn't had to be immunosuppressed for cancer therapy or anything, I kind of sometimes get a little glossy with this with patients. I just gloss over it. I assume they know. Wash your hands prior to, I appreciate Dr. Albalju giving me a fist pump and not shaking my hand as I was snuffing down a shawarma before I came up here to talk. But we really want people to clean their surfaces, of course, separate their foods raw from cooked, even like the plates that they're taking the food out to the grill and get a new plate when you take it off the grill. Most people seem to understand a lot of that. But the touchy-feely with the food, do I have to cook my food beyond rare? I like it a pink steak, you know, I like sushi, you know, and it's like we have to make some sacrifices and really emphasize the impact. If they get a foodborne illness, a mild case might just be nausea and vomiting. Well, that might mean they're not able to tolerate their anti-rejection medication. They might be throwing that up. Or it could be a terrible thing where if their gut microbiome is messed up or something, they could have some translocation. They could get a severe bacterial infection that could lead to organ rejection. And those are very rare, but we have to make patients aware of it and really help them understand and spend a little time on this. Chilling foods, you know, people come up with all kinds of things. Can I go to a picnic? Can I go to a potluck? Well, yes, but you might want to bring your own food, or you might not want to eat the potato salad that's been sitting out in the 90-degree sun for 7 hours. You know, we have to really be patient with people. Tom's more patient than I am, I think. Got it, you know. Wash your hands before you eat. Wash your hands, you know. Anyway, keep working on that. Our booklet goes over this in massive detail, and we have resources in there for patients to contact the USDA or the Michigan hotline for food poisoning if you suspect you have it. New onset diabetes after transplant can occur in all organ transplants. In kidney patients, 10 to 20% may exhibit this at the end of 1 year, and the risk increases over time, and they feel that this might be dose dependent on how long patients are on steroid medication. And then you can see the other organs there as well. So can anybody guess why new onset diabetes occurs besides medication in our patients? Tom mentioned it in the pre-talk. Were you listening to what Tom was saying? Weight gain, yes, Kristen. Ding, ding, ding. She knows. She's referred a few patients to me. So anyway, there is diagnostic criteria for new onset diabetes after transplant. And of course, in some patients with anemia, that A1C might not be that reliable. So we have those other markers. And these have been around for a long time, since 2003, this diagnostic criteria, which is something I learned for this talk. But what are the modifiable risk factors we can tackle as a team, and what are those that are non-modifiable? Certainly, the older the patient, the more at risk they might be for diabetes. Certain ethnic populations, Asian patients, may be more at risk for diabetes. Men tend to be more, and people who have a family history of diabetes. Getting patients off the glucocorticosteroids as quickly as possible, or reducing the levels, can help with this. Trying to prevent obesity or educate people. So again, in that pre-transplant phase, time and time again, even if the surgeon says, we can, sorry, surgeons, I'm quite dismissive, aren't I? Oh my goodness. But even if they can be transplanted, we know that post-operatively, it might be more difficult to manage medication dosing if our patients are in that BMI category 35, 40. So encouraging them to make healthful food changes in the pre-transplant phase can be enormously impactful in the post. We really want them to work on their lifestyle changes now. And sometimes I'll say that they're like, I'm not too bad. I'm like, hey, most people gain 10 kilograms, over 20 pounds in the first year post-transplant. So we really want to pay attention to lowering our body mass index ahead of time to prevent all these other things. And of course, we know that diabetes lowers our immunity. It increases our risk of infection. It delays wound healing. It can lead to other metabolic problems, the weight gain and the diabetes, blood pressure, hyperlipidemia, and other infections. So what do we do? Good old friend, how many of you are out there following the Mediterranean diet? We have Mediterranean food today. Thank you, Dr. Abelju. That is so nice. But definitely, and people are like, what's the Mediterranean diet? It's out there. It's always voted as one of the 10 base diets. And what we really want to encourage people to think about is diet as a means to living, not as something restrictive. We're trying to get rid of the dietitian. We want to be nutritionists. We want to be inclusive and expansive, not limiting and breaking it down to this very smallest little thing. Now, in some cases, therapeutic diets are extremely important, right? Cirrhosis, they really need a very low sodium diet, or if they have calcium oxalate stones, we might need to modify specific nutrients in the diet. Or if they have intestinal malabsorption, post-intestine transplant, we need to work on those things. But really basically trying to eat more plant-based meals, more whole grains, more fruits and vegetables are important. Well, then they say, you can't have grapefruit and pomegranate. I'm like, well, there's about 7,000 other types of fruit we can choose. How about an apple? How about a pear? And there are, I mean, no, I'm minimizing this because I'm old and jaded. This is really sad. But, you want to try and expand their horizons a little bit. And, again, taking into account things like dentition, I can't tell you how many of the pre and post liver patients I'm following that do not have teeth. And it's very sad. And they talk about all the list of things they have to do. And they're like, dentures are kind of on the bottom of my priority list. I'm like, so they can't chew, they can't stand some of them long enough to cook. It's very challenging, and there's been a lot of research done in like loneliness with kidney transplant patients. They dwindle down and become malnourished because they don't have somebody to dine with them. So going a step further into Mediterranean diet when most people are having peanut butter sandwiches or a bowl of dry cereal, we're trying to get people to think of ways to incorporate healthier nutrients. Tom mentioned the exercise portion, of course, avoiding concentrated sweets and foods with added sugar. How much added sugar do you guys think? What's the recommendation? Anybody know? Per day of your percentage of your calories, or grams. I'll take grams of added sugar. So it's 10%. That's what the American Heart Association recommends. So for most women, that's 24 grams of added sugar. And for men, about 36 grams, about 6 teaspoons a day for women. Okay, Mary Grace is looking. Are you going to tell me how much? Because that was my next question. She's like, I came to her lectures before. She's going to ask us how much is in there. She's got the diet. Is that what you have, diet? Okay. And we'll talk about diet. Wow, no. I'm sorry. She's never going to come to another lecture. I'm picking on her, but no, it's true. So when you look at a 20-ounce bottle of pop, take a guess at how much added sugar you think is in there, or 12 ounce. There's 40 in a 20, in a 12-ounce can or bottle. There's 40 of regular, not diet. But we'll talk about diet in a second. And in like a 20-ounce bottle or a 2-liter, there's like 10 times the amount that you're supposed to get. So I hope I'm not belaboring this too much. But Dr. Albajuth said diet's worse, and there's been a lot of scrutiny about artificial sweeteners lately and how that can actually alter the gut microbiome. A couple of the studies I saw done in post-transplant patients, well, the one study I really read thoroughly prior to the talk, talked about 17 people that were already overweight or had a high body mass index of 35 prior to being enrolled in the study, and they weren't really using nutritive sweeteners, and they gave them a challenge, and they found that it did elevate blood sugar, which it's not. That was the Splenda or the sucralose. So everything in moderation. I guess if we're trying to focus on getting people to lose some weight and they're drinking regular soda and they can't live without the caffeine or something, of course, we don't want any cola beverages with our kidney patients, but encouraging them to change up, maybe to a bubbly if they need a carbonated beverage, which we often hear, or a diet soda, but in moderation, right? These drinks are not meant to be taken with every meal in large quantities, and yet our society is like, hey, we'll give you a really big Coke if you want to supersize it to this amount, and we see the consequences, as Tom mentioned. And one caveat on that obesity statistic is, of that group of people that have overweight or obesity, 25% are 100 pounds or more over. So we have like that category that's very, very difficult. And these are people that we may want to refer to bariatrics, either pre-transplant or post-transplant. And I didn't go into a lot of the GLP-1s, but I like the slide. That's from 2020. That's a COVID slide. Uh-oh, you get on the scale. Regular check-in can help. I tend to avoid that on certain. And then I didn't check in for like 5 years, and I went back to the doctor, and they were like, "You've gained 25 pounds." And I'm like, "But it's over 5 years." That regular check-in, that reminder of where we're at, and our patients too. So as Tom said, regular follow-up, getting their actual weight when they come into clinic, and trying to head this off at the pass by making healthier choices. Again, the reasons for the weight gain are those immunosuppressive medications. People feel very hungry, especially with the glucocorticosteroids, leading to excess energy intake. And, they're kind of laid up for a little while and they don't feel like they can move. And then they get into that habit of not moving, or they don't live in a safe neighborhood, or they don't have access to equipment. So really drilling it down to the basics of finding a buddy to go for a walk with or go to the Y. Some people walk at their church, or some people will get one of those little under the desk ellipticals that their dad had, and he doesn't use it anymore. The jury is out on whether those work or not. I think they do, but some people don't think. I just don't think they do it long enough. So there are additional consequences to post-transplant weight gain, and besides new onset diabetes after transplant, but blood pressure can go up, cardiovascular disease or metabolic syndrome risk is higher, impaired end organ function, loss of breath, and decreased survival rate. So we want to avoid all of these. A lot of people will ask me, a lot of patients will say, what is metabolic syndrome? And here's the clinical definition. It was something that was described by the National Cholesterol Education Program back in 2005. And you have to have 3 of these abnormalities at the same time to be considered to have metabolic syndrome. And again, all of the immunosuppressive medications may come together with lifestyle choices and food choices to put patients at risk for this. One thing we didn't talk, did you talk about waist circumference? We don't really measure that here, a little bit, but that's something we can do to get an idea. And I know our liver clinic is using that, and the SICA scale as well, to and also indirect calorimetry with our pre-liver metabolic clinic patients. Most of them are pre, some of them are post, but we use that. So strategies for weight loss are similar to what we see with our patients with new onset diabetes after transplant, really focusing on portion size. Why am I blanking on what it is? Not the CDC, but there's a website you can go to, Portion Distortion, and you can take a portion distortion quiz, and it shows you how Dr. Abelshud and I were, maybe it's the USDA, thanks, Tom. And Dr. Abelshud and I were talking about, or we were talking about this before the meeting, and food supply is so different. And they show a muffin from like 1965, and the muffin was this big, and the muffin is this big, and the hamburger, yeah, the size of the bowls, the plates are bigger. So talking to our patients about using a smaller plate, about putting their fork down. Anybody see me eat at lunch? Don't look at me. But we want people to slow down, put their fork down, take 2, enjoy their food, enjoy the taste, and do that comparison. Sometimes I'll do like that behavior modification thing, and of course our psychologist friends come and play with this a lot as well. But really tasting the food. When you bite into an apple, think of how long it takes you to eat an apple. Unless you're a slow eater, think how long it takes you to eat a piece of apple pie or one of those pies at McDonald's. 3 bites and it's gone, right? So you have to really slow down your eating, enjoy the food, and check in with those feelings of hunger and satiety. Particularly in the liver clinic, we really work on those feelings of hunger and satiety, because someday, somehow, their GLP-1 is going to get cut off, either through Medicaid, Medicare, or their insurance never covered it to begin with. And then guess where they go? That's right, the local medical clinic, or whatever, the urgent care clinic. That's the word I'm looking for. They give people those GLP-1s now. It's the best kept secret in the suburbs. I'm telling you, this is where they get their GLP-1. Yep. Or they get them, what's that? Compounded, yes. And they pay like $176 to $250 a month for 4 doses. But when they get the cost, I mean, I know Mary Grace and the other pharmacists, Medina, can attest to this too. Some patients have copays that get quoted of like $2,300 for the GLP-1s. Yes, hi. That's, oh. There you go. Thank you. Thank you. I love it. Oh my God. So we really want to think about things. And some of these food choices that I have listed on the screen that you guys can see are, of course, related to preventing cardiovascular disease risk, checking with their doctor for exercise, or referring them out to a more tailored exercise physiology program if they have a lot of comorbidities and we're concerned about. We don't want them walking around the track 10 times, 3 days a week if that's not safe for them. Tracking activity with an app or a journal. Anybody got an app for tracking activity or food intake on their? Everybody does now, right? Food to Take, Nutritionix. I tell you what, beyond the GLP-1s, that is the #1 way that people in my liver clinic lose weight. I've had guy, no meds, who's up to 60 pounds, and another lady that Mary Grace probably knows, who has been on a GLP-1. Anna Dina probably knows this lady too. Sorry, Dina, you're back there. They lose weight, quite readily on the GLP-1, but using the app helps hold them accountable. So that is another great way to do it. Surgical intervention, so consideration of bariatric surgery. I know Dr. Abbas Al-Kurd is our really renowned person in understanding, really connected to transplant. We're looking at that. But people who have a body mass index more than 40 with or without comorbidities, or people that have a body mass index of 30 to 30, oh, that's wrong, I'm sorry, 35 to 39.99 with one or more comorbidities. That should be down to 30, right? In the new guidelines, sorry. Yes, I meant to update that slide, I apologize. So I'm not sure how I'm doing on time. I talk kind of fast and then I'm kind of bad little, oh, good, perfect time for the wrap-up slide. So everyone on this team is so critical to outcomes with patients, and we really want to provide interventions both in the pre and post-transplant phase to prevent those post-transplant complications. So if the patient's overweight prior to getting a transplant, let's get them down to a healthy weight prior to the transplant. If they are, putting 15 teaspoons of, turmeric in their pomegranate smoothie prior to transplant, we want to talk to them about, hey, you're a kidney transplant patient and you're on a fluid restriction, so stop drinking a 50-ounce smoothie in the morning. But that's another story. No, but trying to get them to make these modifications ahead of time. And make them in a timely fashion. And that's been a challenge for me, getting to people quickly in the post-transplant phase, unless they're part of our liver metabolic team. That's one shout out to that team. We do see pre and post-transplant patients. The focus is trying to identify patients with stages 2 to 4 fibrosis on FibroScan or a significant amount of scarring in their liver. If they're cirrhotic, we're trying to prevent them from becoming decompensated with their cirrhosis, staying well and healthy. We just had one gentleman we've been working with that doesn't have to be listed right now, and he's going to wait for a while to be listed because he's lost so much weight with his GLP-1 therapy, his diet, and his exercise, and he's doing a lot better. I had old data that Dr. Gonzalez had shared with me back in March of 24. From 2020 to that time, I believe we had transplanted 9 patients that had been part of our MASH clinic. And a few died and a few, were turned down, but it's really making a lot of hope and headway for patients with this. And I can't say enough about our psychologists, our pharmacists, our transplant nephrologists, surgeons. Thank you so much for inviting Tom and I to be part of this lecture today. And we're happy to as always, to answer any questions you might have.